All right, good afternoon and welcome to Virtual Face-to-Face with President Bruce Jarrell. I'm Alex Lukowski, Executive Director of Media Relations. We all know that getting a good night's sleep is essential if we want to be our best, with a sharp mind, reliable memory, good motor control, responsive immune system, and a positive attitude. So why don't we do it? Well, the short answer is it's not entirely our fault. For most of human existence, it was pretty simple. We woke up with the sunrise, we got sleepy when it fell, a very predictable rhythm around the day, circa diem. Now, that was before we invented every kind of thing you can imagine to disrupt the underpinnings of that cycle. Edison gave us the light bulb, which gave us shift work. The Wright brothers gave us flight and jet lag. Babbage gave us the computer, which would eventually become equipped with a blue light monitor that saves battery power, but suppresses our production of melatonin. So we couldn't sleep even if we wanted to. Even the alarm clock is really just designed to wake you up when your body doesn't want to. And believe it or not, you can blame early classes and a professor named Plato for that one. Now add to that alcohol and nicotine, sugary diets, less exercise, obesity, sleep apnea, antidepressants and antihistamines, a noisy and overlighted world, and the ever-present suspense that we might be missing something right now on social media, and you've got a mess on your hands. We're going to add one more thing now. These last months, the anxiety and uncertainty brought on by COVID-19 and separation from the support structures we rely on to get us through tough times. Now, pre-pandemic, the CDC said 1 in 3 Americans suffered from sleep deprivation. A study of 13,000 people in 13 countries released this month shows 70% of them encountered some new sleep-related problems in the last year. According to USC's Keck School, that often includes more frequent, more vivid, and often disturbing dreams. And poor sleep is much more than an annoyance. It's been shown to greatly increase the likelihood and severity of 11 chronic conditions: heart attack, coronary heart disease, stroke, asthma, COPD, cancer, arthritis, depression, chronic kidney disease, and diabetes. So that should be enough to scare you. What's more, a study in the journal Sleep found that drivers who slept fewer than 7 of the previous 24 hours are much more likely to be responsible for vehicular accidents. It's about 30% more likely with just 6 hours sleep, and more than 15 times as likely with fewer than 4. Federal highway officials say in 2017, more than 91,000 crashes and nearly 800 deaths involved drowsy driving. And it's the same in the American workplace. 250,000 accidents and errors, more than $30 billion in losses each year. We spend a great deal of money trying to compensate for all that poor sleep. The global sleeping aids market, that's everything from supplements and CPAPs to sleep number beds, totaled nearly $80 billion in 2019, and it's projected to more than double by the end of the decade. But there is good news. Our guest today, Dr. Emerson Wickwire from the University of Maryland School of Medicine, knows just about everything there is to know, I think, about sleep and how to get it, and he's ready to share some of that knowledge with us. So stay alert if you can and be ready with your questions. I should note that Dr. Wickwire serves on the editorial boards of Behavioral Sleep Medicine and Sleep Review, and is associate editor of the Journal of Clinical Sleep Medicine. He's also director of the Insomnia Program at UMMC Midtown, and this summer will become the school's section head of sleep medicine. But before we go any further, I need to tell you this program is being recorded and will be posted on the UMB homepage, umaryland.edu. In a little while, you'll have a chance to ask your sleep question. Don't wait. Look for the chat button. Select Chat with Host and write your question there. When the time comes, listen for your name. I'll open your mic for you. All you have to do is speak up. With all that out of the way, let me introduce our host, UMB President, Dr. Bruce Jarrell.
Thank you, Alex, and it's a pleasure to be here. I'd like to welcome all of you in the audience. Just as a reminder, these sessions that we've been having, the face-to-face sessions, really address a number of different broad areas. One of those areas is things related to COVID. Another area is related to social justice, and we've done quite a lot of that. A third area is wellness, particularly during the COVID era. And so this particular session is really focused on wellness, your wellness, what you need to do to stay healthy, etc. And I'm pleased to have Dr. Wickwire here to be our expert. So Dr. Wickwire, I'll start off with a question that I know you deal with all the time. Most of us don't know what sleep disorders are. You deal with sleep disorders all the time. Can you give us and the audience a general view of what are the kinds of problems that people with a sleep disorder encounter? What are they and how do you deal with those things?
Thanks so much for having me. It is an honor and a privilege. When we think about sleep and disordered sleep, roughly we're talking about a continuum of two buckets. On the one hand, we have wellness or lifestyle related issues. Some of those Alex mentioned earlier, simply related to how much sleep am I getting? In other words, this is a modifiable lifestyle behavior, and when I sleep, I sleep well and it's restorative and functional in terms of physiology and mental health, but I'm just not getting enough. And this is the biggest lever that that's the field of sleep medicine can pull to improve public health. Now, a smaller subset of individuals experience what we call clinical sleep disorders. And as you know from your own experience as a physician, these really run the gamut and impact every physiologic system from the brain and the neurologic system through the endocrine system and cardiovascular and pulmonary and so on and so forth. So we have sleep duration issues, and then we have sleep disorder issues. And Alex also mentioned sleep timing, and that's important. We can certainly talk about sleep timing and circadian issues as we move forward. So we have sleep duration, disordered sleep, and sleep timing are the three broad buckets.
And when people consult you, are they referred to you, or do they identify this as a problem in their own life? And how do you make a diagnosis here?
At the University of Maryland, we host an accredited sleep disorder center. We're based at the Midtown campus, and we will move our clinical offices into the beautiful new Midtown Tower later this year. In addition to our accredited sleep center, we also offer an accredited sleep medicine fellowship. Typically, we have two physician trainees each year, and we have a broad and growing portfolio of funded sleep research. Now, in terms of clinical care, it depends on the condition. For some conditions, like insomnia, for example, and insomnia means trouble falling asleep, trouble staying asleep, or both, patients are aware of it because they are awake. So insomnia patients often self-refer, or at the very least, they talk to their primary care doctor and say, I'm having trouble sleeping. Now, historically, these were called disorders of initiating and maintaining sleep, DIMS. Other kinds of sleep problems, which historically were called DOEs, disorders of excessive somnolence, in other words, conditions that cause me to be pathologically sleepy, typically take place during sleep. For example, obstructive sleep apnea is a condition where the upper airway collapses and narrows so that I have mini suffocations throughout the night. Now, patients with obstructive sleep apnea think that they are sleeping just fine. But when they come to the sleep disorder center and undergo either a diagnostic polysomnogram, which is called a sleep test or a sleep study, all of us have had one or know someone who has had one, poly for many, somnos for sleep. We study many physiologic functions during the night, or potentially that patient has a test at home called a home sleep apnea test, a sort of ambulatory, lighter intensity version. These patients typically never knew that they were having a problem because they're asleep. So it depends on the patient and it depends on the presenting issue, but we care for the full range of sleep disorders in our multidisciplinary center.
Thanks for that. So I want to remind the audience to please get your questions into Alex so we can get them before our expert here. So why even should we bother to have this discussion during the period of COVID? Well, what's going on that makes this an issue now?
There are really two ways that I think about that answer. It's a great question. First, sleep is sort of like a reliable car. In other words, most of us don't think too much about our sleep until something goes wrong, and then sometimes we raise our hand and ask for help. But the fact is that insufficient and disturbed sleep, as Alex mentioned, can cause or perpetuate or exacerbate the vast majority of chronic diseases that are causing ill health in the United States and worldwide. So sleep is important for memory. We now know that insufficient and disturbed sleep are reliable predictors of cognitive decline. And we'll talk more about those things, of course, during the hour. Now, when we think about trouble sleeping, the kinds of trouble sleeping that has gotten worse during the coronavirus pandemic, this is often exacerbated by stress. And stress is a normal part of life. Some people have a higher baseline level of stress. Some people are internalizers. If we go through loss of a loved one or a job transition or a medical illness, there are lots of reasons why stress can increase at any point in life. What's somewhat different during the coronavirus is we have a double trouble. We have sort of a double whammy where there's a pervasive stress. So to be alive is to experience an ongoing stress where we're uncertain about the future. Now, to a certain extent, obviously, we're in a much better position as a society than we were 6 or 8 or 10 or 12 months ago. But even so, we're not out of the woods yet. So there's a pervasive sense of uncertainty, and that's one of the problems that this has caused. Now, the second has to do with the loss of rhythm. For many professionals, productivity has gone way up. But one of the reasons is that the number of working hours has also gone way up. So we've lost the hop in the car and commute to work or walk to work and then commute home at the end of the day. Those boundaries are gone, and we'll talk more about the impacts of that loss of rhythmicity as well, I'm sure.
And so these are, may I call them secondary effects of a pandemic, as opposed to, are there any known primary effects, that spike protein or other parts of this particular virus, that you think are affecting our neurological function and thus sleep?
On the neurological function, we don't know yet, but yes, certainly there are so many things that we don't know about the neurological impacts of COVID. It's an almost certainty that there are physiologic neurological effects changing the way the brain functions across the 24-hour spectrum. Now, in terms of COVID, conceptualized as a pulmonary disease, there actually are a number of studies demonstrating worse, for example, oxygen desaturations in patients who have comorbid obstructive sleep apnea, along with the coronavirus. So there's a neurological component and a pulmonary component in addition to the general stress or perhaps even psychological or psychiatric component.
So we certainly are seeing that for cardiac effects, myocarditis and COVID, certainly clotting effects with COVID. And I've seen a few reports of direct observation of neurological effects, for example, in people who have died from COVID. I guess that's going to be a slowly evolving science, so isn't it, to understand that?
One of the studies that I found very interesting used a technology called an accelerometer or an actigraph, which is a research grade Fitbit, or it's more accurate to say that Fitbit is a commercial grade actigraph. And using ongoing actigraphic assessment across the 24-hour day, researchers have been able to reliably identify and even predict COVID symptoms just by looking at physical rest and activity cycles. In other words, when am I more or less active? So we can think about movement or digital kinds of footprints, and that's another way to conceptualize the impacts of COVID.
Just a lot to learn in that whole area, and it's who would have thought that little old virus would have such a profound effect on all of us?
14 months later.
It's just 14 months later. You've also mentioned, and other people have mentioned, this strange drug called melatonin. Could you talk about that just a little bit? Because you can get that over the counter. You hear the military has industrial grade melatonin. But what can you tell us about that before we get to specific questions?
Sure. Melatonin is it's a hormone. It's a sleep-related hormone. But melatonin, although people use it this way, unless you're taking higher doses of melatonin, it's not a quote-unquote sleeping pill in the same way that a prescription sleep aid might be considered a sleeping pill. Melatonin is produced by the pineal gland, which is roughly equidistant with the temple and the third eye, if you think about moving backwards from the face into the brain. This is secreted at the onset of darkness. So Alex earlier in a very thoughtful introduction mentioned the fact that since the Industrial Revolution, rest and activity cycles have changed because of the advent of light. If you think about the sun going down and then we have a night and the sun comes up and we have a sunrise and we have a day, there's a dusk and there's a sunrise. Melatonin typically onsets during dusk, and it tells the brain not go to sleep, but it sort of sets the stage for sleep because we've evolved to be diurnal creatures. Humans have evolved to be asleep at night. That's one reason, of course, why there's such an increased rate of accidents and so forth with shift workers, because we're hardwired to be asleep during those hours. Now, your question pertained to melatonin. Melatonin can be very effective as a timing agent. So shift workers, for example, the American Academy of Sleep Medicine recommends 3 milligrams of melatonin post-shift prior to sleep. The caveat is that melatonin is very, very light sensitive. And what that means is that if you are not controlling light exposure, you might as well not take melatonin. So popping a melatonin a couple hours before bed and then watching television or surfing the internet or looking at your phone, it's just like you didn't take melatonin to begin with. So we recommend that patients wear blue blocking glasses, for example, and you really want to control all aspects of light exposure.
And it has a different meaning for light sensitivity, as opposed to the drug itself deteriorating in light. You're talking about the drug losing its effectiveness in people as a result of light.
That's exactly right. And I think with an audience like that we have today, where there are lots of people with patient kinds of questions, it's important to realize that your body can't metabolize as much melatonin as you can put in your hand and swallow before bed. So sometimes we hear patients taking 10 or more milligrams. Particularly as we age, we lose the ability to metabolize that melatonin so quickly. So in older adults, melatonin can actually, at high doses, can increase fall risk the following day because the melatonin is still in the blood.
Fascinating, fascinating stuff you never read. So,
well,
go ahead.
We're delighted to be a resource here, and so so it's in our interest, of course. We want to help spread the good word.
Yeah, and that's important, obviously. I want to get one other piece of information from you, and then Alex tells me we've got a number of questions, so we'll move to them. So my last thing I think that the audience would be interested in is it's been discussed that there are secrets to getting a good sleep. How you prepare, what your bedroom should be like, all of those kinds of things. Could you give us your wisdom on what works, what we should be thinking, what surprises there are in there, etc.?
Of course. Think about 2 pieces of the puzzle. The first piece is to create a sacred bedroom environment for sleep. That environment should be cool, quiet, dark, uncluttered. This should be a calm, soothing space, to the extent possible, devoid of stimuli. Everyone's heard the recommendation, or many of us have heard the recommendation, only sleep when you're in bed, or only the bed for sleep and sex. The reason is that we want to create a cave where, as we enter that space through repetition, we train our body and brain that this is a space for sleep. You can think about it like going to the gym or going to the iron working studio. You wouldn't do your taxes in either of those environments. It's sort of the same environment here. We really want to create create a place that we can, through repetition, train our brain and body that this is what it's for. It's one reason why we so strongly encourage patients when they're having trouble sleeping not to stay in bed. Otherwise, you're actually practicing, of course, having insomnia through repetition, training yourself that the bed is a place to be awake, which is the opposite of what we want to do. Now, once we've worked on that environment, blackout shades or earplugs or a white noise generator, for example, make sure that there's no clutter, piles of papers or piles of clothes, and that the environment is suitable for restful sleep. We now want to create a ritual in which to enter that sleep. And what we do clinically, what I talk with patients about is think about your day in terms of sections, red, yellow, green. So if I'm at peak performance during the workday, this is when I'm maximally engaged and having wonderful conversations like this, or doing other aspects of our jobs. And we want to create a boundary so that we come home and now maybe there's a green zone. This might be time with my family or leisure activities or exercising or whatever it might be. It's distinct from my active day. And then, of course, the green buffer zone, again, steps down where I have my pre-sleep kinds of activities, changing into my pajamas or nightgown, brushing up and washing my face, and these sorts of things. So by leveraging and purposefully creating environmental cues, we can manage our internal emotional and physiologic states to really set the stage for reliable and restful sleep.
But there's something you didn't say, which I think you need to say, and that is your computer, your workstation should not be in your bedroom then, should it?
So it certainly shouldn't. On both of those sides, computer and social media kinds of cues need to be addressed. In the bedroom, we really, your dresser is fine. And if you are a good sleeper and you enjoy reading in bed before you fall asleep, that's fine. But ultimately, everything in the bedroom environment should be focused on sleep itself. The bed is not a place to relax. The bedroom is not a place to socialize. Every cue should be, it's like an athlete preparing or an actor or an artist preparing for their trade or for their craft. And if it doesn't advance the sleep mission, it should be out of there. Now, in terms of the stair-step approach that I mentioned, we also want to think about that very purposefully. So it may be that at the end of my sort of red zone workday, I shut down my computer. And that's one behavioral marker to create the buffer zone where I'm going to have family time. And it may be even that the marker between the red, to end my evening time is that I place my cell phone in the kitchen and I'm not going to look at it again until the morning. So absolutely, we want to be managing technology lest it manage us.
Great advice. So why don't we move to questions since we're about halfway through. Alex, why don't you fire at will?
I'll tell you, your discussion has sparked a lot of questions. Early on in the discussion, you talked about sleep apnea, which sounds terrible. I want to bring Kathy Martin in. She has a couple of questions specific to that. Kathy, are you there?
Yes, I am.
Go ahead.
Thank you so much. Sleep apnea has been an issue that I've had to deal with my husband as well as with a family member. So I have a family member who was diagnosed with central sleep apnea and a husband who was diagnosed with obstructive sleep apnea. And so I would like to hear more about central sleep apnea. That was something that I had limited knowledge about. And then the follow-up question is, now that I sleep with someone who wears a machine, how do I sleep?
I so appreciate the questions, and you've asked a lot, so let's move through those piece by piece. First, I think it'll be helpful for the viewers to understand what obstructive sleep apnea is. And if you think about your body on the beach at age 12 relative to, I can tell you're older than 12, the muscles lose patency, right? As we age, our muscles get softer and become more, let's say, collapsible. Now, the same thing happens in the upper airway. Those muscles lose patency and become more collapsible over time. Now, there are factors that increase risk for obstructive sleep apnea in our country, obesity, and globally, obesity being the single most important one. And the reason is that what obesity does is it means that my lungs can't fully expand. And so if my lungs can't fully expand, when my diaphragm contracts, I can't generate as much air pressure out to hold the upper airway open. And I'll return to that idea in just about 15 seconds. Now, the upper airway collapses, not enough air can get through, so my blood oxygen drops and my brain begins to panic, where again, the patient doesn't know that he or she is awake, but when we monitor the brain during sleep, we see the brain continually trying to wake up, essentially saying, hey, I'm suffocating, I don't have enough oxygen here, help me out a little bit, okay? And as a result, obstructive sleep apnea increases risk for the dozen chronic conditions that Alex mentioned earlier, as well as massively increased economic costs and worsened quality of life. In obstructive sleep apnea, the problem is that there's not enough space in the upper airway for air to get through. So any solution to obstructive sleep apnea needs to increase space in the upper airway. And for most patients, particularly with with moderate to severe obstructive sleep apnea, the most effective treatment is what's called positive airway pressure. And this gently blows soft, warm air through the nose or through the nose and mouth to inflate the upper airway, just like a balloon or just like you'd fill up a flat tire, so that you can sleep and breathe normally and naturally. Now, if you think back to what I said earlier about obesity and air pressure from the inside, if I can't generate enough air pressure, then the upper airway can't stay open and I'm in trouble, okay? Now, by contrast, central sleep apnea, which is far less common in the general population, although in some patient populations, particularly those with heart failure, central sleep apnea is actually quite common. Central sleep apnea has to do with a neurologic breakdown between the brain and the diaphragm. All breathing follows a four-step cycle. The brain sends a signal to the diaphragm contracts, air is pulled into the lungs, and oxygen and other nutrients are extracted and pumped by the heart throughout the body. In obstructive sleep apnea, the system breaks down because the signal happens, number one, check. The diaphragm contracts, number two, check. But the airway is closed, so I can't get air into the system. That's where it breaks down. In central sleep apnea, the signal never moves from the brain to the diaphragm, and so the treatment approaches are somewhat different.
Thank you.
Alex, that's a great description, by the way, Dr. Wickwire.
Yeah,
I learned a lot from that. Go
Yeah, me
ahead.
too. That was very good.
Yes.
So we have an anonymous question. Someone writes, if you're unable to sleep, what are some tactics you can use to fall asleep? And when would you know if you had a serious sleep problem? And how does someone, you mentioned that people come in, they thought they had a good night's sleep, they thought they slept through the night. How can one know that one has a sleep problem?
So I'll answer the second question first. If you're asking that question, it's a good sign that you have a problem, because the vast majority of patients suffer far too long before they check with their primary care doctor or before they seek a specialist consultation. If you're wondering, do I have a problem, 9 times out of 10 or more, the answer is yes. Talk with your doctor. That's point number one. Now, in terms of what's the threshold, of course, that is variable and difficult to answer in a webinar. But generally, what we think about is trouble sleeping 3 nights a week or more for 3 months or more. That's a reasonable threshold to think about whether a condition is chronic.
Okay, let's bring in Emily Parks, who has a question about, as she puts it, those ever-present screens. Emily, go ahead.
Yeah, so how many hours before going to bed should we get away from our screens? And then even if we do our best to stay away from them and we wake in the middle of the night, what should we do in order to not grab that screen again?
Again, thank you for the question. It's a thoughtful question. I'm going to answer the last part first. Your phone shouldn't be in your bedroom unless there's a pressing reason why it needs to be there. spend the $5 to buy an over-the-counter, a plug-in alarm clock, and leave your phone in another room. Think about sleep as occurring in a protected space and time. So one of the things that we do, for example, with patients who, and they often do, I wake up at 1:30 and I wake up at 3:15 and I wake up at 4:45. The fact that you know that is a problem. If you wake up in the middle of the night and look at the clock, it's like taking your finger and punching the emotional centers in the brain. So get the clock out of there. This should be devoid of external stimuli. There's no reason for you to be looking at your phone or doing other daytime activities in the middle of the night. Now, the second question was, when do we need to cut off our electronics? And the answer is, A, it depends. B, earlier than you are now. At minimum, 60 to 90 minutes. If you're a good sleeper and being mindful of your sleep health, 60 to 90 minutes. If you are a type A, if you are a hard driver, if you have feel a lot of pressures from your daytime work or your family, you may well need more time than that.
None of us feel pressure these days, Dr. Wickwire.
Certainly not me.
And where am I going to listen to my YouTube before I go to sleep? I got to listen to YouTube, to music. Alex, what else you got?
All right, well, I'm going to bring in Eric Nielsen if I can find him on my list. Oh, he's down there. And I'm sure he's asking for a friend because he's asking about snoring. Eric, go ahead.
Yeah, my friend would be my wife.
Oh,
Absolutely.
you shouldn't say that.
No, so I've got I've had every device that I can think of. I've taken the sleep apnea test, and it doesn't warrant a CPAP machine or the PAP. I forget, the positive airway pressure. And I've had a device hold my jaw closed. I now wear a dental device that keeps my jaw forward to keep the airway open, but now it's switched from a kind of a throat snoring to a nasal snoring as I wear this device. So it's better, but still there. So the wife is still not happy. And then I have a second question, if I may, about alarm clocks. Is there any research on your end that shows the light emitting alarm clock is a benefit, or should we just stick with the sound alarm?
This is 3 questions in a row that I'm going to answer the second part of the question before the first. I love the light emitting alarm clocks. We purchased one. We used it for a couple years. I think they were a great idea and just less jarring than sort of a typical blaring alarm. There's no scientific evidence that's reliable that suggests you're going to sleep much better with 1 or 2. It's a personal preference, but personally, can't hurt to check it out. The first part of your question is very difficult to answer, obviously, over the webinar. What I'd encourage you to do is to follow up with ENT. If you haven't followed up with ENT, of course, your primary care, if you have a sleep disorder specialist. Part of what you mentioned has to do with what we talked about earlier, that the problem in obstructive sleep apnea, and snoring is simply very mild obstructive sleep apnea in terms of a continuum. The problem is there's not enough space in the upper airway. So just the same way, when you're a boy and take a blade of grass, or a girl, and take a blade of grass between your fingers and whistle, the whistle comes from the blade of grass vibrating. That's what snoring is in the upper airway. The upper airway partially collapses. Your brain still needs just as much oxygen as it did before, but not enough air can get through, so the tissues vibrate as more air is forced through. Why has your snoring moved from the upper airway into the nasal space is too much for the call, but those are the folks that I'd talk to first.
Alex says the questions are rolling in. So Alex, let's keep it moving.
All right, I'm going to bring in Mary Phelan, who has a couple of quick questions, I think. Mary, go ahead.
Hi, thank you. Dr. Wickwire, I was wondering, even though you said the phone should not be in the bedroom at night, is there, for those of us who do have trouble falling asleep, is there a particular app on the phone featuring nature sounds or meditations that you would recommend? I know there's a lot of those on the market. And my other question, I think you had answered from a previous caller about how long before bedtime should the screens be unplugged. So I'm working on that. I am. So anyway, my first question about the apps. Thank you.
It's my pleasure. There's no particular app that I'll recommend over another app. These are personal preference. In terms of bedtime wind down kinds of routines, the mechanism is we're trying to create a transition. We're trying to create a sacred space. We used to use in our clinical trials when I was doing training, white noise generators. Functionally, that's just what the app is doing. So if you find one that works, stick with it. I'd caution you that this shouldn't become a major focus. You don't want a 6-hour audio book that just sort of redirects your attention and now keeps you awake later into the night.
Alex?
Okay, well, Gina Bacchus has got another question related to a sleep aid. Gina, are you there? Oh, well, oh, there you are. Go ahead, Gina.
Sorry. Well, thank you for having me, Dr. Wickwire. You were already kind of answering my question, but I recently saw an ad for a product named Smart Nora Sleep System, and it's a device that goes and it inserts under your pillow, and it inflates and deflates like a balloon. And there's like this computer mouse-like tool that picks up the sound of your breathing. So if you snore, then it will lift up your pillow and kind of open up your airways. So as you're talking about what snoring is compared to sleep apnea, I was just wondering if it would be effective for actual sleep apnea, or if it's just like to help with the snoring, the mild sleep apnea.
I'm not familiar with that particular device, although the concept has been mentioned several times over the years. Really what you're asking about are alternate or sort of home-based approaches. And we're advocates of evidence-based therapies, and these are serious medical conditions. Do not try and treat your own sleep apnea at home. You're placing your brain and your heart and other vital organs at risk. It's certainly talk with your primary care. These are areas where we provide top-notch care for patients every single day. And whether it's with us or someone else, if you're concerned about having a significant medical problem, make sure that you're talking with someone who has the credentials and expertise to help treat that significant medical problem.
How many devices are there on the market for this problem? It must be a really high number.
There's a really high number. There are. And what we found is that not much works better than CPAP with continuous positive airway pressure when patients use it. So the best approach, and when I say not very much, what I really mean is nothing. It's the most effective treatment. It works if you work it. Now, therefore, what we want to do and what we practice in our center, we want to have multidisciplinary support, because by any measure, CPAP involves lifestyle change. This is a lifestyle behavior. You're now going to learn to sleep with a new device that some patients adjust in a couple days, some patients it takes a couple months. And there are medical or physiologic potential barriers, there are technical potential barriers, and there are behavioral or motivational potential barriers. And in our practice, we try and care for the whole patient by addressing all of those potential areas of concern.
Great. Alex, keep rolling.
Well, since we're talking about CPAP, it was a great comment from Anne Faris, and let's let her amplify, because a lot of people don't realize this can be a lifesaver. Anne, are you there?
Yeah,
What do you want to tell us?
CPAP has saved my life. I had no idea I was not sleeping. A friend of mine who's non-medical, he had kind of sinus infections. Went to the doctor and they put him on a CPAP machine, and it cleared up his sinus infections. But for me, he kept telling me I needed to have a sleep study. And I kept saying, no, I'm sleeping at night. I'm sleeping at night. And finally, I I did have one done, and I have not been sleeping for years. It was just unbelievable. And the difference within 2 weeks, the difference that I noticed in being able to sleep was phenomenal. So I definitely, you have to have a sleep study. That's the way you're going to be diagnosed. It's just, and it's worth it to do it. My other question, though, is now you see these implant devices. What is your opinion of those compared to using a machine?
So first, I'm delighted to hear about your successful sleep experience and sleep treatment experience. Those stories and patients sharing those stories the way you just did is really why we do what we do. It's deeply rewarding. We hear these stories very often, and that's just the kind of experience that we hope to provide for our patients, whether they're colleague, employee of the system, patients, whether they are healthcare providers, whether they are community patients. We want our patients to be saying just the same thing. So you didn't mention if you were cared for at the University of Maryland, but
I was.
yeah. So I'm really glad to hear that, and thanks for sharing the story. The second point that I'd make is your experience has the potential to improve outcomes. Dr. Jarrell had mentioned cardiology, we've talked about neurology, treating sleep apnea and achieving the same kinds of quality of life benefits that you've mentioned also does things like reduce hospital readmissions, increase longevity, reduce mortality, and reduce costs to the healthcare system. And that's what we do.
Can I add one other thing? Is my cardiologist actually told me last year that the biggest difference he sees in patients who have long-term survival is whether or not they are consistently using their CPAP machines. And I've gotten to where I can't fall asleep without it. I have to have it with me. I travel with it. I take it all the time. It goes to Europe. It goes wherever I go. It's amazing.
So Ann, I have to ask you a question. First of all, hi, nice to hear from you.
Yeah.
So what did you notice that was different? Because you said to begin with, you thought you were sleeping fine. And now you're saying there's this radical difference. What's different?
Well, first of all, I have more energy than during the day. I was also noticing that when I was in meetings, I would be sitting there and really having a hard time concentrating, having a hard time actually, you thought you're awake, but you weren't awake. You're sitting there with your eyes going up and down. And then the one thing I really noticed was driving, that I couldn't drive more than a half hour before I would start to feel like I was nodding off, especially if the sun was out and the car was warm. I mean, I almost went off the road a couple of times. Never realized it was because I wasn't sleeping. It's just amazing.
Well, I hope you weren't falling asleep in any of my meetings.
Not yours, no, but Tom's, yes.
Oh, I got it, Tom's, yes, okay. All right, Alex, let's move to the next one. Thanks for that, Ann.
I just want to note that the CPAP discussion has launched numerous directions in the audience. And one of them is about apparently there's a surgical option for cutting away for the airway. And the question is that a better approach, or is the CPAP? What do you think about that approach?
Sure. And I think that earlier a question had come up about implants that maybe I didn't address squarely. So I'll talk about those together. First, there is a role for surgical treatments in obstructive sleep apnea, and for two reasons. One, in very select patients, surgery can improve outcomes in obstructive sleep apnea. After we've moved through a series of very closely monitored medical steps. And certainly our surgical colleagues would describe themselves as thoughtful and cautious surgeons. So we don't want to present the fantasy that if you just go see a surgeon, sleep apnea is going to be gone forever, because more than half the time that's actually not the case, even if you have surgery. Now, certain surgeries can be highly effective in carefully selected patients. So that's a blanket answer. Now, on the flip side, the American Hospital Surgical Association, or the anesthesiologist recently, in the last several years, released a clinical guideline surrounding the aggressive screening for obstructive sleep apnea in surgical patients. So it really works both ways, because untreated OSA increases risk for accidental death and poor outcomes in surgical patients. So we really should be screening from a systems level aggressively to identify occult sleep apnea in many of our patient populations. Our surgical patients, our cardiovascular patients, potentially our endocrine or diabetes patients, our depression patients, and so on. Occult sleep apnea, the prevalence rates are often 40% in these populations, and it worsens outcomes. Okay, that's point number one. Point number two is, again, in carefully selected patients, there is promising data around various kinds of stimulators. So these are implants that do things like tighten the genoglossus muscles, again, to increase the patency of the upper airway. Now, there are important inclusion and exclusion criteria for who is a candidate, but with all of these more invasive procedures, what we really want to do is make sure that we've done far more than just an old college try. We really want to make sure that these patients have had every opportunity to succeed in far lower risk treatment procedures.
I'm glad you mentioned implants, because Barry Friedman was asking about that. Lisa Coomer has asked me to ask this for her, and I think it's a question many people have, especially over the last year, where there's more stress in every part of our lives. She writes, if your mind doesn't want to shut down, what can you do when your mind races over the day's events or perhaps the next day's events? What can you do to get to sleep?
Well, if you've waited until you can't sleep, you've probably waited too long. What we know from a number of studies over 30 or 40 years is that various metrics of stress, whether it's metabolism in the brain, whether it's galvanized skin response, whether there are stress hormone levels like cortisol and adrenocorticotropic hormone, all of these proxies for stress, pupillometry and oxygen rate, oxygen consumption and so forth, all of these show elevated 24-hour rates in patients with insomnia. So oftentimes the experience of the patient or even the non-expert provider is the patient is overactivated at night. In a minority of cases, the patient is overactivated at night. In the vast majority of cases, the patient is overactivated 24 hours a day. And what I mean by that is that it's not that your brain is overactive only at midnight, it's probably overactive at noon as well. And so what we need to do is to begin to create some of that rhythm, some of which has become very difficult during COVID for reasons we discussed earlier, so that I can increase my engagement during the working day and then maximize my disengagement during the sleep period.
Alex, the hour is going
Okay,
fast.
I know we're
It's just
getting through a lot of
intriguing.
questions. This is really good.
So-
Amy Connor.
So keep going.
I'm gonna bring Amy Connor in here. She has a question about a particular issue she's experiencing. Go ahead, Amy. Oh, well, Amy was asking about migraines. She said that she wakes up with migraines at least once a week. What could be going on that would cause that?
Several things, of course. One is that there's a robust, well-documented bidirectional relationship between migraines and insomnia. The causality is very difficult to determine. From a biological footprint perspective, if we look at the brains of patients with migraines or insomnia or post-traumatic stress or depressive disorders or other anxiety disorders or chronic pain for that matter, brains are going to look very similar, and we don't yet understand why some patients have depressive disorders and other patients have anxiety disorders. The science doesn't fully understand those mechanisms. The second thing that's important is that morning headache is a reliable predictor of undiagnosed obstructive sleep apnea. And the reason is that when blood oxygen levels drop during the night, that of course can cause a headache. These are wonderful questions, and my global assessment here, or my global feedback to our audience is, if you have questions about your sleep, if you're experiencing the kinds of symptoms that our colleagues and callers have asked about today, talk to your doctor. It's past time to talk to your doctor. Let your doctor manage your care or make a referral. There are folks who can help, and there's no reason to wait and keep suffering.
All right.
Thank you, Alex.
Here's someone you know, Monica Maggiano. She has a question about kids and sleep. Monica?
Hi, yes. I would say the biggest impact to our sleep during the pandemic has been a not sleeping child. A 4-year-old sleepwalking, sleep talking almost nightly for a year. And so, as sleep deprived parents, that impacts a lot of what we're doing. But what are some strategies or tactics that we can use on younger children?
We were speaking earlier about how easy it is to communicate and understand brief answers. That is not a brief answer. I will tell you a very funny story. A close friend oversees the pediatric sleep medicine program at Children's National in DC, and our own son is 7. And several years ago, he began to demonstrate bedtime resistance. I think he was 3 at the time. And here I am as a sleep disorder specialist and a psychologist on top of that. So if anyone should be able to solve this problem, of course it should be me. And after about 3 weeks, I had had enough and I was at wit's end. So I called my friend Danny and said, Danny, what do I do? And he said, are you free? I said, yes. I put him on speakerphone and he solved the problem. So it's a real issue, these sort of parenting transitions regarding our children. What you're describing are called parasomnia behaviors. A parasomnia takes place when part of the brain that should be asleep is awake. And that's why, for example, your 4-year-old son or even adults who do things like sleepwalk don't remember. It's because the majority of the brain is asleep, but part of the brain happens to be awake. Now, the good news is that the majority of children who experience sleep terrors, I'd ask if your son had sleep terrors, and I would guess yes. You don't need to answer that, but most children with sleep terrors grow out of them. A subset continue to develop sleepwalking. Most children with sleepwalking grow out of it, but a subset continue to maintain sleepwalking even later into life. The most reliable antecedents for what are called non-REM parasomnias that you're describing now are stress and insufficient sleep. Now, in children, the most important thing to do is to make sure that your son is well slept. We don't exactly know why insufficient sleep or stress trigger the parasomnia activity, but they do. So make sure that the child is as comfortable as you can make him or her, and make sure that the child obtains as much sleep as you can, and that'll reduce the frequency. Safe bedroom environment, no sharp objects, put pillows next to the bed. If there's any risk at all of a safety concern, obviously talk with your healthcare provider or pediatrician. But also know that as long as the environment's safe, he or she will likely grow out of it.
Thank you. That's just, every one of these answers is kind of fascinating. So Alex, go ahead.
All right, I'm going to bring in Eric Schutz. There's a question about waking up in the middle of the night. Eric, are you with us? Go ahead.
Can you hear me?
Absolutely.
Okay, thank you for taking my call. First, in the middle of the night, if you wake up and you have trouble getting back to sleep, what's a reasonable amount of time before you get up and leave the bedroom?
Use your gut. And if you are convinced that you're not going to fall back asleep, it's okay to get out of bed and only return to sleep when you are return to bed when you are highly confident that you are ready to sleep. What you want to do is get as much practice as you can getting in bed, falling asleep quickly, and staying asleep. So if there's any breakdown to that pattern, rinse and repeat. Get out of bed, only return to bed when you're highly confident that you're ready to sleep, so that you can practice falling asleep quickly and staying asleep. The reason that I said trust your gut has to do with a question that came up earlier. If you're looking at the clock, it's like running a road race, but tying one, having your shoelaces tied together. You are waking your brain up at just the wrong times. So do not use the clock. You do not need a minute-to-minute estimate. with practice, what you'll find is you can actually redirect yourself back towards sleep from that half awake state. So avoid the clock, practice getting in bed, falling asleep quickly, and staying asleep.
Thank you.
You mentioned the clock, and I just have to ask, someone asked earlier in the chat, you said you should only be in bed when you're going to sleep, or when you're asleep, right? You get up, but we love to hit that snooze button on the clock. Is that okay? I mean, can we do that? Is that going to damage our sleep cycle somehow?
You'd be better off sleeping in a little bit later. If you're having, these are wonderful questions. Think about the context of our discussion, what we've discussed. There is a pandemic or an epidemic of insufficient and disturbed sleep. And if you're needing to snooze, by definition, what you're saying is, I am sleep deprived. And it's a sign that you're not getting enough sleep. And there's only way you can get more sleep. You can go to bed earlier, you can sleep in later, or you can nap. And for most folks, going to bed earlier or sleeping in later is a more reliable strategy than napping, because most of us have jobs during the day and so on and so forth. So if you're fighting to wake up in the morning, it either means that you're not getting enough sleep or not enough quality sleep, which of course could be due to an undiagnosed sleep disorder.
Alex, we got time for one more question.
Well, okay. Well, I'm gonna put this out for someone because it relates to campus policy, and you talk about napping, and and it's true. In some cultures, they take a nap in the middle of the day. Now that may be environmental; it's very hot in the day, but it's prevalent in a lot of areas. What would you think about a campus-wide siesta or an opportunity to take I don't know what it would be, 15 minutes or, some break. Is that a good idea?
Alex, how can you ask a question?
I'm asking on behalf of it's not me. I never nap,
The metaphor I was going to use, what I'm going to respond about the biological basis for a Spanish siesta. And I'm also going to use a metaphor of being a matador watching that bull just storm right past. I'm going to move out of the way of the charging bull of the campus policy question. There's a biological basis for siesta, so it's not just because it's hot in the middle of the day.
Okay.
Sleep is influenced by two factors, at least. The first is called the sleep drive, or the sleep pressure, or the sleep homeostat. It increases just like hunger or thirst. And what I mean by that is the longer that you go without sleeping, then the sleepier that you get. If I spend all day on the couch, the slope of that line will be flatter. If I'm out running a marathon, I will build up sleep need even faster. Now, if all that were happening is our brain were building up sleep need, of course, we'd all fall asleep pathologically sleepy during the day. So at the same time, our brain secretes an alerting signal that oscillates on a 24.2-ish cycle that keeps us awake and then comes down during the evening, and then it comes up again the next day. The reason that I'm telling you this is that alerting signal dips sometime between 1 and 3. So if you look at tracings for these hormones, what you'll see is that it's not because you had a big turkey sandwich at lunch. It's because your brain is hardwired to have a lull right after lunch. So there's a biological basis for the siesta.
You see that, Dr. Joe? And that's why we have napping pods in the campus center, right?
I didn't know we had that.
We do. I was reminded that by a viewer here.
Well, this has been a really stimulating discussion. So first of all, Dr. Wickwire, I want to thank you for giving us your time and your thoughts. I have a feeling there may be a redux of this, Alex. What do you think?
I think so.
Another one. But I want to thank you. Most stimulating. I think you're going to have to send your contact information or how to get a consult with you. A lot of questions. For those in the audience, I hope this was enjoyable to you. I hope you learned a lot. I certainly learned a lot. I look forward to our next session. So again, thank you. And during the times of COVID, I wish you health and well-being. So thank you all very much.
Take care.
Bye.